Good afternoon, ladies and gentlemen, and thank you for waiting. All lines have been placed on listen-only mode, and the floor will be open for your questions and comments following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Elena Bauer. Ms. Bauer, the floor is yours.
Thank you so much, Ron. Welcome to VHQC's second educational webinar focused on adult immunization. Preparing for flu season. Act now to protect your patients. I would like to go over the agenda quickly. First, I will introduce a video testimonial about a family's influenza experience. Next, we will be presenting information about the 2015 influenza recommendations by Heather Crouch, followed by a Q&A portion. Next, we'll have a polling question about what are your barriers to influenza immunization. This will assist us in determining what technical assistance can be provided to improve immunization rates. Next will be an introduction to our online community where you can find tools, resources, and educational information to assist you with improving immunization. And lastly, we'll have a presentation by Dr. Bruce Walter about the FluFit program with a Q&A to follow. Let us begin. Just a quick note about VHQC. VHQC is a quality innovation network, quality improvement organization for Maryland and Virginia. VHQC convenes patients, providers, and stakeholders to rapidly improve health quality and to achieve better health, better care at lower cost. We do this work through the CMS QIO program, the cornerstone of Medicare's efforts to improve the quality and value of health care for its more than 45 million beneficiaries. My name is Elena Bauer, and I am the Improvement Consultant at VHQC, supporting the Adult Immunization Task, where we are focused on improving immunization by improving documentation, assessment, and reporting. I just want to quickly remind you that August is National Immunization Awareness Month. The next is a link to a YouTube video about a family and how they were affected by the flu. It is a very good video to use to help patients understand the importance of getting their influenza. So please utilize this tool. The next is another video about flu. This is Gigi's story. She is a teacher who always stated that she never got sick because she had immunity being around all the kids. But unfortunately, she did get sick. And so now she does get influenza immunizations every year. So once again, it's another way to impact your patients, to see a testimonial from another patient on the benefit of getting the influenza vaccine. Just a little bit of data. You can see that our current rate for influenza is about 42%, and the goal is to get to 70%. That's national rate. And for Maryland rates, you can see we're running around the same amount, around 42, and we would like to get to 70 as well. At this time, I would like to encourage you to check your EHRs and to run your immunization report to see what your rates are for influenza. This will help you to identify where you need improvement and what you can do to improve, and how you're doing when you do improvement processes. How do we improve these rates? One way is to provide education about adult immunization and also to provide tools to improve immunization assessment. Our next presentation is by Heather Crouch. Heather is a PharmD. She's the Medical Science Liaison for Vaccines at the North American region for GlaxoSmithKline. Thank you, Heather, for taking the time to speak with us today.
Absolutely. Thank you, Lena.
You're very welcome. I've handed over the webinar to you so that you can continue forward with your slides.
Wonderful. Thanks so much. And for
Thank you.
of the presentation today, we're going to do a little bit of a flu clinical overview. But first and foremost, I would be remiss if I didn't offer a huge welcome to everyone on the line. I know right in the middle of your busy day, it can be a really hard time to settle in and sit down and really focus on something. But we really appreciate your time and certainly all of your efforts surrounding immunizations, but right now in particular influenza. You know, it's a very special time of year. I know everybody's excited that flu season is upon us. We've already got flu doses shipping, flu vaccine doses shipping, so we really are going to be ramping up very quickly in terms of immunization efforts. It just kind of feels like we just ended last flu season. But all that being said, one of the major opportunities that Lena has already talked about is education of patients and really providing information that helps them understand the importance of preventive services and the importance of immunizations. But what's really important as well is education for healthcare providers, where we get a chance to speak as colleagues and we get a chance to walk through information that allows us all to be true advocates for immunization and not just someone who suggests a vaccine. So I really appreciate all of your time and your efforts around that as well. We have a couple of topics that we'll cover in this section before turning it over to Dr. Waldhope, but I think it's a really important a few pieces of information that will help you again in your conversations with patients. The first sort of core component that I want to speak to are the immunization recommendations themselves. As many of you are already aware, for vaccines, every year ACIP, the Advisory Committee for Immunization Practices, in conjunction with CDC, issues their immunization schedules. There's a pediatric one, there's an adult one, and then contained within those are obviously each of the vaccines, various age recommendations, and then obviously other conditions that would be reasons to vaccinate as well. What we're going to focus on today are the flu portions of the immunization schedule, and then as well, you guys are very fortunate. The hot off the presses flu recommendations just posted a couple of weeks ago, so we have very timely information that hopefully will help you get started with your immunization season. What you're looking at on the screen is actually Figure 1 and Figure 2 off of the adult immunization schedule. That's the yellow bars at the top. And then the bottom portion of the slide is actually the footnote. And so the story I like to tell with vaccines is very much akin to the Wizard of Oz. It's follow the yellow brick road. And you'll note with vaccines, anything yellow is routinely recommended. And it's really a striking demonstration of the importance of flu immunization when we look at the top figure, which is age-indicated vaccines, age-recommended, 1 dose annually. Everybody gets a flu shot. Or if you look at the second chart strip, if you will, from Figure 2, which is other reasons to vaccinate, medical conditions, other indications, you can see across the board it's all yellow as well. So influenza vaccination is recommended across the board in the adult space and as well in the pediatric space. We'll touch on that just a bit as well. But a seasonal flu dose annually is top of the list. It's the first recommendation. It's the first vaccine on the immunization schedule when we look at adults. So again, I think it speaks to the importance. And there's such an opportunity for population-based health management here because flu immunization, particularly as we approach a higher rate, that 70% or beyond, for the Healthy People 2020 goals and the National Immunization Survey goals, if we can really achieve that, obviously the protection of the community can be gained. There are various pieces to the adult recommendations, but overall, the basis is anybody 6 months or older should receive a flu shot, and there are a range of products that are available in that space. This is actually how it looks and reads for the pediatric schedule. Minimum age is 6 months, with the exception of live attenuated vaccine, and that's 2 years. And again, routine vaccination. It's just really straightforward. There is some language surrounding utilization of LAIV, or flu mist, is the branding that you may be more familiar with. And so in particular, there's some guidance there. But I think the main takeaway is, it's top of the list for adults. It's a routinely recommended vaccine for children as well. Everybody gets a seasonal flu vaccination. As we move into the updated recommendations, I mentioned the schedule gets updated each year, but as do the influenza recommendations. So each year they put out a publication called Prevention and Control of Influenza with Vaccines, Recommendations of ACIP. They update it by season. The last full recommendation, just to give you some perspective, was 2013, I believe, for that 2013-14 season. They were updated in 14-15 and then updated again for 15-16 influenza season. The full recs are not published every year simply because Because it's such a routine vaccination and such a routine recommendation, there aren't a significant amount of changes. So a 50-plus page document every year would actually be a heavy lift, and honestly, I think the most up-to-date information would probably be lost. So what I wanted to focus on is the updates for 2015-16, and then walk you through that information, and then we'll take questions. There are a few, as I mentioned, pieces and parts to implement the vaccination if you want the full recs that are available from 2013. And just to give you the backdrop for how this came about, the public meetings, ACIP holds 3 meetings a year, but the February and June meetings of 2015 really encapsulated the flu discussion, and then obviously this publication occurred just a few weeks ago. So the updates, 1, 2, 3, and 4 are the basic updates for this flu season. I will tell you the strain composition, the antigenic composition for this year's flu, and it has changed. Obviously, we got a lot of feedback from as manufacturers last year, but also as healthcare providers about vaccine mismatch, evolution of the strain, particularly one of the A strains. So there has been a change, and I'll show you what that strain change has been. The products available for this season, and we'll just go through some basics of those, an overview. There is an updated algorithm for children. In the last few years, it had gotten a bit complicated on the heels of the 2009 H1N1 pandemic. So there has been an update, and I am very happy to inform you it's a simplified update in terms of the algorithm, so we'll cover that. And then there are some updates surrounding LAIV and the recommendations for use. I do want to start off with sort of an oldie but goodie. Who do we vaccinate? When do we vaccinate? Some of the basic questions that seem to hold over year on year. Routine flu vaccination is recommended for anybody over 6 months of age. Obviously, contraindications notwithstanding. We'll cover some of those a little bit later in the talk, but overall, anyone without contraindications should be vaccinated. Ultimately, we need to start our shooter clinics. We need to start our flu vaccination before the onset of flu activity, and really the timing is sort of that September time frame. ACIP in their Ask the Expert section and other information surrounding flu vaccination, as soon as you have flu doses, you can get them. They are applicable for the entire flu season. You can start vaccinating. Obviously, for back to school, if you have doses, that was certainly a great opportunity, which speaks to avoiding missing opportunities for vaccination. So when you get doses, you can give them. Very much want to get our influenza vaccination series started by October if possible, because we do, from an epidemiology perspective, start to see viruses circulating. We tend to see our A viruses kicking in a little bit earlier, and then a little bit later in the season we'll see B viruses emerging, and that's been the trend actually for the last several years. In order to not miss an opportunity, anyone that comes in for a routine healthcare visit, they don't necessarily have to be coming in for a flu shot or an immunization visit, but having that conversation more frequently rather than less can oftentimes catch people who might not have been vaccinated otherwise. There's always the question of, well, should I wait? How long do these vaccines last? And I think that's a really important conversation. Every year, flu vaccines have to be reapproved. So every product every year is a new product, essentially. It's formulated much by the same mechanism. We may change the strains or whatnot for that year, but we have to immunologically assess whether that vaccine works every single year. And so over time, antibodies will decline. They will go down just as you would expect. But what we do know is that starting your vaccinations in September will actually protect people throughout the season, although their antibody titers may start to fall by the time June and the expiration of the vaccine rolls around. So please don't wait. Please don't miss an opportunity. And a single vaccination for the season is protective. So what's in the vaccines for this year? When we look at the 2015-16 seasonal flu vaccines, they will contain the trivalent or 3-strain vaccines will contain 2 A strains and 1 B. And so I do want to point out that the A strain, the H3N2, is a different virus. It is a different strain. This was the strain from last year that really evolved unexpectedly and very quickly. And so we very much had to change that A strain composition for this year to make sure that we ensured coverage with vaccination. The B strain from last year was also flipped. It was a Victoria lineage. There's 2 types of B strains that circulate. We switched that in the trivalent to the Yamagata lineage. To accommodate those B strains that circulate now, there are quadrivalent influenza vaccines that are available that your facility may be utilizing. And so the switch in the B virus really isn't an issue because both Bs are contained in your quadrivalent. But in your conversations with patients and someone who had, the flu shot didn't work last year, there was vaccine effectiveness noted. There were reductions in hospitalizations and consequences related to influenza. It just was unfortunately not a great year for that strain to be matched with the vaccine. That has been updated. We've now seen consistency throughout the southern hemisphere season, which supports this selection for our northern hemisphere season as well. So these are your changes. There's a California strain and a Switzerland strain of A, representing H1N1, all the way back to our pandemic in 2009, same type of virus, and then H3N2, and then the two B lines in your quadrivalent are represented. The dosing here, the information is relatively small, so I'll apologize for that, but it's dropped directly from the Morbidity and Mortality Weekly Report. And it does go through every vaccine manufacturer and then a couple of other pieces of information that you may get questions about. So to orient you, the first column is the trade name, the brand name, and then the next is the manufacturer. The presentation, i.e., is it a prefilled syringe, is it multi-dose vial, that is actually listed. And then the next is mercury or thimerosal, which has historically been used as a vaccine preservative and is now really relegated to your multi-dose vials because, again, you're getting into them repeatedly. We want to make sure that contaminants are not introduced. Ovalbumin or egg protein content is also listed for a number of vaccines. What I also want to call out, please pay attention to the products that your facility is using based on age indication. It's really important. They are all a bit different, although manufacturer within will have some consistency. But please be aware, this is a notable place for vaccine error and maladministration, i.e. giving it outside of an age indication. So please make sure that you are using a product that's age appropriate for your patient selection. There's also information containing latex and then the route of delivery, whether intramuscular, intradermal, or certainly intranasal is an option as well. It just continues to go through the table. We move from your quadrivalent, now indicated as IIV or inactivated influenza vaccine 4, into your standard dose IIV3, which is your more historically based trivalent vaccine, 3-strain based vaccine. And you can see that you start to see fewer and fewer manufacturers offering trivalent as we move more into a quadrivalent type coverage in the influenza vaccine field. There are a couple of other new types of vaccines over the last several years. You have cell culture-based, which is designated as CC, IIV3, which is your Flucelvax, and then within the recombinated space, or RIV3, this is a recombinant type vaccine known as Flublok. So you can see the various brand names. Just please, if you'd like to go to this publication or look at the package inserts, they're actually quite consistent. Please make sure that the age indication is appropriate for the product and the formulation that you're using. This just actually continues on into your LAIV, known as Flunis, and this is a quadrivalent product as well, and as you can see, the various presentation, age indications, etc. This one is a bit different, more different than most, and an age indication of 2 through 49 years. I talked a bit about the change in the childhood algorithm, so I want to point that out to you. Historically, you were counting fingers and toes and asking parents and digging into records and getting all sorts of information. But over the last several years, we've seen an enormous amount of stability in the H1N1 pandemic strain. It was solidified in 2009 and into 2010. It remained stable. It sort of fell off the radar screen. It wasn't as big of a contributor to disease over the next year. Then it came back, and then it went away again. But there have been no significant genetic changes in that. The reason I point that out, that was the kicker. You had to have a vaccine that contained that strain. There was some confusing language for providers surrounding that. It's very simple now. For kids 6 months through 8 years of age, up to the 9th birthday, 2 doses are required if they've never received 2 doses in total before. It does not have to be in the same season, so I do want to point that out. But we find accumulated immunity takes a bit of time, in particular to the B strains in these vaccines. So the little ones really need the 2 doses to get themselves started and establish some primary immunity. But over time, you only need 1 seasonal dose because you're exposed to viruses circulating, and you can get some boosting immunity that way. But in order to optimize response, the first time they get vaccinated, they really do need a series of 2 shots or 2 vaccines at least 1 month apart. And so the simplification is the 2 previous doses, period. So if someone got a dose in 2009, another one in 2012, that counts as their 2. So for this season, they only need 1. It can be a mix of trivalent and quadrivalent, this one or that one, this one and that one. It can be any sort of, it could be an injectable or it could be an intranasal formulation. All of those count. So really making it simple. If mom says, if dad says, if there's documentation of, even if they're not in the same season, 2 previous doses, they get 1 shot this season. So it really is much more simplified than in years past. Live attenuated influenza vaccine garnered a lot of conversation. In 2014, looking at a review of evidence, ACIP recommended at that time that LAIV should be used preferentially for children aged 2 through 8 years without contraindications. However, follow-on information from subsequent flu seasons indicated an update to that language, and there is no preferential statement for LAIV anymore at this point in time. We'll continue to follow. There's certainly lots of conversations about how vaccines are delivered intranasally and what type of immunity that generates or injectable. But at this point in time, if you have LAIV, then give LAIV. If you have injectable, give injectable. But do not miss an opportunity to vaccinate, as there is no preference expressed for either type of vaccine. Both are warranted for protection, and both are recommended. If we look at egg allergy, this is also another conversation. Very, very interesting that the updates over the last few years from the Allergy and Immunology Association and specialists in that area. Persons with a history of egg allergy who have only experienced hives should receive influenza vaccine. And in fact, individuals who can eat even lightly cooked eggs should also be vaccinated and are very unlikely to be egg allergic or allergic to a flu vaccine. So someone who's familiar, obviously, with reactions and manifestations to egg allergy, and then monitoring patients. This isn't particular to egg allergic patients. Many patients can have a syncopal reaction to vaccination, not just flu vaccination. So ACIP has updated their recommendations. The manufacturers have started updating the language in their indications and in their product labels. Please watch patients. Sometimes they get excited, particularly your adolescent patient population, sometimes your adults. But just simply watching folks to make sure that they're okay. Either they're not having an allergic reaction, they're not having some sort of adverse reaction, and that they don't become syncopal. If they're getting it, they can sit in a waiting room and read. They can, walk around and stay on the premises. But it really is just being extra conservative to make sure that patients don't have a reaction. Persons who have reported reactions to eggs, such as angioedema, respiratory distress, dizziness, lightheadedness, or recurrent emesis, or if they've required epi or have had another medical intervention, they can be vaccinated if they're over 18 years and there are no other contraindications. This is specific to your recombinant flu, but again, the overarching statement is there needs to be someone that is comfortable administering the vaccine in case someone does have some sort of allergic reaction. Contraindications. You're going to have a lot of people that will have an excuse to not get vaccinated, but the reality is, if you look at this middle column, there are very few true contraindications to influenza vaccination, and it really does circle around severe allergic reaction, i.e. anaphylaxis. So someone who has a previous anaphylaxis reaction to a vaccine dose obviously should not be readministered. There are some additional language that ACIP would like to recommend that are particular to LAIV, and that it should not be used in pregnant women, immunocompromised adults, egg allergy of any severity, and then adults who've taken antiviral medications recently, because it's a live vaccine. Antivirals would actually interrupt with the replication. Precautions are very similar to what you would see with most other vaccines. Moderate or severe acute illness may be a reason to watch them more closely, but is not necessarily a reason to defer vaccination. And then the conversation with flu vaccination around Guillain-Barré syndrome, that's a risk-benefit assessment on behalf of the provider and the patient. In the sort of end of my presentation today, I promised Lena I would talk a little bit about vaccine storage. So something very near and dear to our hearts in the manufacturing industry, but this has also been a big focus for the Institute of Medicine. There were noted a number of errors in terms of storage and handling, and so I just wanted to offer a few best practices, a few reminders, and then sort of close out with a discussion around flu vaccines in particular. These vaccines, all flu vaccines, are refrigerated vaccines. And you can see from sort of the temperature gauge at the top, we really do need to remain in refrigerator temperature range. The most egregious storage error is exposing a vaccine to freezing temperatures if it is not a frozen vaccine. This can denature the proteins in the vaccines and can render them inactive. So please, 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 if you're not using continuous data loggers, continuous data monitors, that is a recommendation actually by your state health departments now. Certain types of refrigerators are no longer recommended, such as your dorm-type refrigerators and those pieces. But be very careful with your vaccine storage and handling. Obviously, this is extensive inventory, and we certainly don't want wastage, but we also want to make sure that the vaccines are as potent and as stable as possible. So if you do have a temperature excursion, please note it. Please contact the manufacturer to make sure that the vaccine is still viable. But again, the freezing temperature is going to be the most impactful, and you would definitely need to set those vaccines aside, and they would have to be discarded. So some more best practices. Again, there are very few frozen vaccines, with the exception of MMR. So please make sure your MMR is kept at frozen temperatures until utilization, but all of the other injectable vaccines, including influenza vaccine, are definitely recommended to be refrigerated. And so if they go high, document that temperature excursion as well, but also call the manufacturer, because we do have some stability data above a recommended temperature range. So keep the door shut, don't open it and close it and open it and close it. Sort of the standard stuff you tell your kids with your refrigerator at home. But make sure that you are storing your vaccines properly. Don't use the dorm-style refrigerator, like I mentioned. And make sure that there is a lot of education conducted for your staff to make sure the vaccines are handled properly. Another area that is really important as well, when you get your vaccine shipment, unload it immediately. Don't let it sit around. You actually can maintain cold chain after shipment if you unpack your vaccines and put them in the fridge immediately. So in closing, sometimes with flu we have to treat it a little bit different. Those are the basic recommendations for vaccines, including flu vaccines. But when we talk about influenza season, oftentimes we'll see shooter clinics. And so looking at single-dose vials, looking at manufacturer-filled syringes, those are obviously designed for single-dose administration. There are also multi-dose vials that are available for flu, and that's relatively uncommon in the field of vaccines these days. So make sure that proper cleaning technique is used when drawing up your shots for your shooter clinics, your flu clinics. But as well, once something has been drawn up for use, or you've got everything set out for your clinic, they really should be utilized the same day. That is language contained in the ACIP recommendations because, again, we do want to maintain the sterility and the non-contamination of these vaccines as well. So it's not just storage in terms of your cold chain, but also handling of the vaccines once you plan to do a clinic. And so with that, Elena, I'm actually going to bounce it back to you. That's the end of my clinical part. And we will take any questions and go from there.
Thank you, Heather, for that great presentation. I know that we have had a couple of chat questions that have come through, so I'll start with those. But if anybody does have a question, they would, Wes will tell you how to call through. Wes, can you do that?
Certainly the floor is open for your questions. If you have a question or comment, please press 7 on your telephone keypad. There's a question from Wendy Jennings. Wendy, the floor is yours. Wendy, if your phone is muted, please unmute your phone. Okay, in that case, there are no questions at this time.
Okay, so one of the questions that we got in the chat was, Heather, can you explain what is the latest guidance on whether family members of someone who is immunocompromised can get the flu list?
Yeah, I think this is an excellent question because we do get a lot of folks in the 2 to 49 age range, obviously even in adults, that don't like needles and they would prefer an intranasal preparation of influenza vaccine. You duly noted in the immunocompromised population, we do not recommend live vaccines to utilize. However, because of it being an intranasal preparation, it can be administered to family members and sort of the folks around that person. So that's a very astute question. There is not the expectation of shedding of even vaccine virus to an immune-compromised individual. So a very, very great question. As long as they get immunized, they can be immunized. It does not matter which type of preparation.
Okay, thank you so much. Patients with comorbidities like cardiac disease and diabetes seem to be at a higher risk of getting the flu. Are there specific recommendations about these types of patients?
Actually, this is a great one, Lena, because we're starting to see this conversation not just with flu vaccines, but with all vaccines. And in fact, if you look at Figure 2 of the adult immunization schedule, each of these conditions is specifically called out as a reason to vaccinate, and I think that's a major takeaway. One of the conversations, you just talked about immunocompromised patients, immune deficient patients. We also have to look at some of these more chronic disease patients as possibly not being the best candidates for your live attenuated virus vaccine either. But they really should be vaccinated. It is a reason to vaccinate. And just as you mentioned, the consequences, it's not as much that they're at greater risk for getting influenza, but they are at much greater risk for developing sequelae and severe consequences from influenza. So thank you very much for that question and for that comment.
And then I have one more chat question. How long can the vaccine be exposed or not refrigerated?
Ooh, you're never supposed to take it out of the refrigerator. How do you like that, Lena? Is that a good answer? Yeah.
Yeah, that's great. So not at all.
Not at all. No, that's actually not fair to say, and it's not obviously real life when you're trying to vaccinate, particularly on a mass immunization clinic. We do recommend, obviously, vaccines be kept refrigerated at all times if possible, but we do know that for shooter clinics, they can be pulled out, they can stay out. We do have stability data at the room temperature up to 72 hours. So we don't recommend storing your vaccines that way, but there is the full recognition. We have to have that data because that's really how vaccines are used. So room temperature, 72 hours, and that's acceptable. But please document any time out of refrigerator on your boxes in the event that all of your vials are not used. And then once a pre-filled syringe is activated, it should be used that same clinic day. So, or if you have a syringe that's been drawn up, it should be used that same clinic day. So a couple of conversations there. But thank you for that question. And I pay attention to the storage and handling.
Thank you so much, Heather, for your presentation. We really appreciate you taking your time. And you have so much knowledge about vaccinations. It's just great to have you have this presentation and share your knowledge. Thank you so much.
Thank you.
Okay, now moving on, we have a polling question. And this polling question is based on what barriers impact influenza immunization for adults in your setting. So can we have the polling question placed up in the chat area so that the participants can participate? So the 4 answers are billing and payment issues. Patients do not ask for the vaccination. Influenza vaccine is not offered at my setting, or other. And then if you can just pick one of those and then just submit. Okay. So now we're going to move on. The information that we'll get from this polling question will help us to develop individual plans to help immunizers to improve their practices. Okay, you can see what the answers are there. It looks like the most is other. Okay, so I probably will poll the participants just so that you can comment on what you mean by other. Thank you, everybody, for participating. Okay, I just want to briefly introduce you to our online community. This online community gives tools and resources on immunization. It also has tools and resources for improvement in PQRS and meaningful use, diabetes, and also cardiac. Those are other tasks that we are working on as well. So please look at our online community and see if there's any tools or resources that can assist you. I also want to highlight the assessment tool that is found at the Immunization task online site. This is a great tool from the CDC, and it's a way for patients to determine what their vaccine needs are. This can be put on your portal as well. It's a great tool. So I just want to talk real quick about immunizations are preventative care. It's preventative health. The benefits of preventative care are better health, lower cost, better quality, and it also saves lives. It's a great way to assess what patients need to prevent illness. And this leads into our next presentation by Dr. Bruce Walpole. He's a gastroenterologist. He received his training at Eastern Virginia Medical School, and he's currently the Associate Professor of Clinical Internal Medicine at the same institution. His topic is going to be flu fit screening, and what flu fit is to do screening while you're doing the flu immunization. So Bruce, I'll let you go ahead and take it away.
About how to save lives and to really utilize data from years of study and research from the American Cancer Society and National Colorectal Cancer Roundtable that we know what works, and the question, just like with vaccination, is how do we go ahead and implement it? Last year, the American Cancer Society, along with the Center for Disease Control, set a national goal to have 80% of Americans screened by 2018. Currently, nationwide, and certainly in Virginia and Maryland, we're at about the 65% range by any American Cancer Society screening guideline. There are certainly barriers, both in terms of cost and insurance, but also just in terms of knowledge. The single most important reason why, amazingly, why patients do not get colorectal cancer screening is because their primary care physician, if they have one, does not recommend it to them. And that includes patients with insurance. So what we're going to talk about today is a unique opportunity during flu season with vaccination, because we've learned something with vaccination, also with cancer, that it's far better to prevent the case of advanced disease and to try to learn how to tweak and better manage an advanced case. So we're going to talk about today what the national goal is, what FluFit is, briefly give you some of the resources to help you organize, set up, and track your results, and clearly educating both the community and patients, and also physicians will be part of this. If I could have the first slide, please. And we go to the 80% by 2018. This is the national goal set by the National Colorectal Cancer Roundtable, which was organized and set up by the American Cancer Society and the CDC. The next slide really shows you where we are with colorectal cancer mortality under two different scenarios. If we keep on doing what we're doing now, or if we can improve to 80% by 2018, overall we will save about 200,000 lives between now and 2030. That's really a huge difference in the number of Americans out there who would not be suffering from colorectal cancer. If I could have the next slide, this slide graphically shows about the patients who remain at risk. On the far left, in the lighter green, 65% of people are up to date with their screening. The smaller percent, 7%, have been tested but are not up to date. And about 28% have never been tested. Now, the testing intervals are important from a public health viewpoint because colonoscopy is every 10 years. If they are at average risk, you have a good exam and there's no polyps. Even high-quality stool testing with FIT test and advanced fecal occult will still require testing every year with a set of challenges that will involve how we track this, even the tests that are given out, how we record the test, and how we follow up on those that have not followed through. If we look at the screen, or if we look on the far right on the screen, we see of those who have not been tested, surprisingly, 24% are uninsured, but interestingly, 76% of the people, the vast majority, are insured patients. Now, why do people with insurance coverage not get colorectal cancer screening? Number one reason, as we said, from the research in the American Cancer Society, is the primary care doctor did not mention it to them or emphasize the importance and or follow up after the recommendation's been made. It really takes quite an effort, both in terms of a champion at a health center, federally qualified health center, even a physician's office, or then a health system to make sure this is tracked in some way using electronic medical records if possible. The other thing is there's the unworried well. Nobody in my family's had colorectal cancer until somebody does, or barriers due to fear or embarrassment. If we look at the next slide, we see that the national recommendations from both the American Cancer Society and the U.S. Preventive Public Task Force agree in the two main ways that screening is being done, either a colonoscopy every 10 years or stool testing every year, and to emphasize it must be done annually. So if you don't have the mechanisms in place to even track the number of cards given out and the lack of follow-through and making sure it gets done, it's going to be a lot harder to track that over 10 years. The next slide shows what the colon looks like, and it's shaped like a big question mark. And I've spent the last 30 years, since I actually began at Hopkins 30 years ago this month, doing colonoscopy, really trying to do what we can to decrease risk of colorectal cancer. And it really took a fairly long period of time to show that we actually were saving lives by removing polyps. Colonoscopy today is better than it used to be. The preps are better. The preps are easier. The sedation's better. But still, a large percentage of the population either will not have it because they will not accept it or they cannot afford to pay for it. If we go to the next slide, the bottom party line is the best test in terms of screening. It's the test that gets done. Colonoscopy every 10 years really overall will decrease the need for any follow-up over that time, no further stool cards, if they have a good exam and they're not at high risk and there's no polyps. It is more costly initially, and again, that test is operator dependent. Access is somewhat limited. Interestingly, certain patient populations, and this has been found slightly more in the African American population, are less likely to allow themselves to have a colonoscopy, but may be willing to undergo stool testing. The next slide really shows a study from several years ago. This group on the left is offered fecal occult blood testing, the group in the middle colonoscopy, but a minimally to slightly higher percentage rate of people offered both tests will undergo screening. So again, emphasizing the best test is a test that really gets done. If we could have the next slide, let's talk a little bit about stool test. The green card on the left is the time-honored fecal occult blood testing. And there are several problems with this, and we've really gone ahead and graduated to either higher sensitivity fecal occult blood testing or the FIT test. So years ago, patients would be given 5 or 6 cards to be taken home and may or not return it, and that's really sort of a major endeavor to collect that number of stools. The FIT test requires 1 stool test at home. It can be sent in to either the national lab or to the provider, where it would probably be sent on to the national lab most of the time. If we have the next slide, let's talk a little bit about stool testing issues. The most important thing I can say is that a single stool test in the office with a rectal exam should never be done. Let me repeat that again because that's so important, that only about 5% of colorectal cancers will be picked up that way. So you're really giving somebody a false negative test. That's just not an accepted screening test recommended by any national society. So the stool cards require multiple cards in the advanced highly sensitive tests or the FIT test, which is a one-time test. It requires annual testing. And while we're calling it flu fit, maybe we could coin the term flu unfit. Who would be unfit or should not be having a fit test, because not everybody's a candidate. These are only for people what's called average risk. And I really need to remind everybody, we need to remind all providers, all patients, average risk doesn't mean low risk. It's still a number 3 common colorectal cancer in terms of mortality and frequency, but there are people talking about in a second who are higher risk. The next slide, we're not going to really go into in any detail, but it talks about high quality stool testing. If you just focus in on the blue part, at the upper part, they talk about looking at the old hemoculture, see sensitivity for cancer between 13 and 50%. Well, that's fairly low. But if you look lower down, you see with the FIT test, you're listing between 55 and 100%. It's really about 73% overall in the larger studies. But if it's done repeatedly in a similar fashion as a pap smear does, it'll really decrease mortality because colorectal cancers, the evolution, most colorectal cancers come from a precancer stage called an adenomatous polyp, and it takes years for that to happen. That being said, these are generally the stool tests are much more sensitive for detecting cancer rather than preventing it. So the current thinking really is if we can prevent cancer with a colonoscopy, that's probably the most efficient way to do it, but not the least expensive way. Let's go on to the gist of what we're going to talk about. What is a flu fit program? And I want to emphasize it is a program. Just like any program you're trying to implement, we define it, the population at risk, where we're going to do it, who's going to do it, and how we're going to track it. So annual flu shots are certainly an opportunity to reach many people who need colorectal cancer screening. When we look at federally qualified health centers, for example, we've had a number of programs where this is being done. It really can work out very well. The patient can do the test at home, emphasize done in the privacy of their own home, and returns the kit. Generally well accepted by patients who have not been able or unwilling to accept or afford colonoscopy. If we go to the next slide, why do we do this? Because we can really incorporate its routine public health practice during flu season. It has to be done annually, and I want to emphasize that this is not for people who are at high risk with a prior history of polyps or family history of colon cancer. If you have a first-degree relative with adenomatous polyp or cancer before the age of 60, your risk of colon cancer is at least double, and those patients should be offered colonoscopy. Let's go to the next slide. If we can talk a little bit about, most importantly, how to set up your program. If I could say one single thing about a program is you have to have a champion to coordinate this. Even in affluent areas in private practice, if there is not somebody who takes responsibility to making sure that each and every patient where you have the intent to have colorectal cancer screening, whether it's a colonoscopy or stool test, you need a real champion. This has been shown time and again by the American Cancer Society with patient navigators, and it's probably the single most important thing that there's a dedicated person to make sure that each person who is offered testing, at least that's recorded, have an idea of the gross number of population that you have, of the number that accept willing to be tested. The third column would really be the number of people who really do have their testing, and number 4 would be the mechanism that you use by phone call and mail, and there's some days that some people need 2 or 3 reminders to make sure that that happens. Second thing is to train your team, and it's really a whole team. It's beyond the scope of our time for this conversation, but we really have wonderful online training program for FluFit, and there'll be links to that at the end of this program. The third thing is to choose the time and locations and advertise that we're going to be offering the flu shot and the stool test. I may be dating myself, but I remember growing up as a child, going to the large local high school where everybody got their polio sugar cubes, and it was a great public health event. And I think that if we are able to handle this in our communities in Maryland, D.C., and Virginia, we can really sort of lead the way for the rest of the country and share what we're able to identify, record, and accomplish. You have to have a system, as they say here, to follow up to the patients who receive the kits. It's really not good enough to say, well, we had 100 patients from our area who returned the kits out of 120. Maybe you offered it to 250. So we really need to be able to track data so we can improve what we're doing and how we're doing it. And remember, any patient with a positive test on a FIT test absolutely must have a colonoscopy. That's true for the fecal occult blood test also, but FIT tests are less likely to give false positives. The VA systems have been looking at this in several national studies over the last few years, and more will be coming with that. Let's go to the next slide where we talk about eligibility with FluFit. And I want to think of FluFit, and if we could coin our own term of unfit, or really meaning they need to have something done better to keep them healthy and fit. So when should a patient be offered the test? Number 1, if they're 50 or older, that's the average risk patient for population screening in the United States. If they've not had a colonoscopy in the last 10 years, was colonoscopy an average risk people is felt to confer protection in populations of people for 10 years, and if they've not had a test within the past year. Now, if we look at the next slide, by extension to that, who should not be offered the test? Well, if somebody's less than 50, they're not a candidate for this because that's what we're not doing population screening, or if they've had a colonoscopy or test. But most importantly, the highlight in blue there is if they have symptoms, this is not a screening test for symptoms. If you have rectal bleeding, blood in the stool, anemia, pain, diarrhea, constipation, those people really need to be evaluated in a far different manner. Those are not screening patients. Those are symptomatic patients that need medical evaluation and likely with a colonoscopy. If they have a family member with a first-degree relative with one relative with polyps or cancer, younger than 60, or two second-degree relatives, they really meet the American Cancer Society criterion for screening at age 40 with colonoscopy. And if they have a personal history of polyps or cancer, they're not at average risk, they're at high risk. And finally, our patients with Crohn's disease and ulcerative colitis need biopsies to look for dysplasia under the microscope, and a way that stool testing works that would not help those patients. So if we put both of that together, the idea is who should have flu-fit testing? People who really choose to not have a colonoscopy or cannot have one for whatever reason, who are at average risk as defined by the American Cancer Society criteria by being 50 or older and no first-degree relatives with polyps or cancer and no signs or symptoms. If we go to the next slide, let's talk about talking. Talking with patients with colorectal cancer. It's important to educate both patients, but really providers also in your area. There's no question that the single most important thing is for the doctor to say that this is important to the patient. And it's important that the tests are completed and returned. So, you really have to number the total number of tests that you have needs to be obtained from a number of commercial and national laboratories, and to make sure that they're returned. And maybe to find out why things aren't returned, if patients choose to not do them. It might just be fear. Studies have shown that reminders can double return rates. Certainly 2 or 3 times can be reminders. I know in our breast cancer project where we have community health advocates in 32 areas in America, and in one of the large areas in Portsmouth, Virginia, and talking to the women who help educate women, it takes between 3 and 5 times reminding women to get a free mammogram. So it's kind of amazing. It's kind of like telling kids to go to bed. It's not so easy. Finally, in the last 2 slides, I want to show you, next slide is the American Cancer Society Program Implementation Guide. And this really could be a 4-hour discussion in itself, but this really talks in a step-by-step way how to implement what we want to do. We know that colorectal cancer is a national health problem. 132,000 Americans each year, down from 150,000 each year, will get this cancer. People do not have to die from this. This is a preventable cancer. If we could have everybody have a colonoscopy, we would dramatically decrease the colorectal cancer rates. They are coming down, but they're not coming down fast enough, particularly in populations at risk, particularly the African-American population, and men in particular. We need to do more. We can do better. We know how to do it. Now, we know what we need to do. We even know how to do it. Now we just have to implement it. As one of my professors once said, do it right, do it now, and do it yourself so you know it gets done. This will have the step-by-step guides on here, and they will talk about the things that we talked today to identify the population you want to serve, where you're going to do it. Make sure you have a navigator who's going to take responsibility of this. Collect the data. If you have to do it on a piece of paper, that's fine. Put it into a computer if you can. The final slide, looking from University of California, San Francisco, will give sort of their 5 steps. And step 1 was put together your team. You have to have a team to do this. The doctor has to be involved. You have to have a navigator, and people in community organizations. We've done this, churches and other organizations can do this in your community that you want to be involved in. Choose time and places for FluFit. An advertisement. Maybe your healthcare system or hospital is going to say, well, or businesses, if we can't get people to get colonoscopy, this is an additive way to help this happen. You have to manage a patient's flow and to see who's being screened, who wants to get screened, who doesn't get screened, develop symptoms to support follow-up of the kits dispensed, particularly of the tests that are positive. And if you do things in that fashion, and you can record it, and we can share it together, we will share it throughout our division, the American Cancer Society, and with other divisions, and really hopefully make a world with less cancer and and hopefully by 2018 we can lead the way in Virginia, D.C., and Maryland to make sure that 80% of Americans get screened for colorectal cancer. So on behalf of the American Cancer Society and our entire team in those states and our divisions, thank you very much for the opportunity to share some time with you today. This will be archived online, I understand, to try to get it to other folks, and I'd be happy to take any questions, concerns, or even complaints. So thank you.
Thank you so much, Bruce. That was a great presentation. If anybody has any questions at this time, you can also do it in chat.
As a reminder, for a question or comment over the telephone, please press 7 on your telephone keypad.
So, Bruce, I have a question. This is Lena. Where can an organization get the kits to perform the flu fit?
Great question. If you just Google fit testing, you will find that a number of national labs do it. LabCorp does it. I believe Quest does it also. There's a company that we have here. I know they're in Virginia, I believe in Maryland, called Polymedco, Polymedco. They all use the same principle. The stool's taken in a little container and put in there. That seems to be one of the biggest barriers. I know that with some of our local health clinics have gone ahead and contacted them. And, you know, if you're buying them in bulk, you should go get it at a very low rate. It might even be like $5 instead of $40 per test.
So the flu fit program is basically that when a patient comes in to have their flu immunization, that this kit is also given to them at the same time.
Absolutely.
Okay.
But I have to emphasize we have to make sure that we have the kits, and you want to go ahead and order them. And I'm not sure they're talking about healthcare systems online or federally qualified health centers, but you want to have the kits, and you want to record every single one that's given out and have a contact way to get a hold of that person and let them know ahead of time, you know, where to bring it back or how to mail it in so that we can really record what's being done. This really saves lives. This is as big a deal as vaccinations.
It sounds like it's a great program and that it would be easy to implement because you're already giving the flu vaccine at the same time. So.
Absolutely.
All right, thank you. At this time, I don't think we have any more questions. Thanks again for your presentation, Bruce. It was a very educational, and it sounds like it's a very easy thing to do to implement and practice. Once again, I just want to reassure you that the PowerPoint and presentation will be on our online community. Please refer to that. It will be a few days before it's posted. And then once again, please take a couple moments to complete the evaluation. And if you have any further questions or comments, please don't hesitate to contact me. It's ebauer@vhqc.org. Okay, at this point, we're done with the presentation. And we have a polling question, if you wouldn't mind answering. So the first is, do you currently offer colorectal screening, yes or no? And the next is, what are your barriers that impact your ability to offer colorectal screening? Staff has not been trained to perform this assessment, we're too busy, billing issues, or other. Okay, we'll be getting those results in a moment. Once again, that's my contact information. Okay, do you currently offer colorectal screening? It looks like the majority was no. And what are your barriers? It looks like the majority was other. Okay, once again, we'll poll to see what those other issues are. Once again, thank you so much for taking part in our second presentation on immunization. If I can be of any service, once again, please don't hesitate to contact me. Thank you.
Thank you. This concludes today's teleconference. We appreciate your participation. You may now disconnect your line at this time.